Yeah, it depends on the person. So we're really transparent about money. That's one thing that in medicine I was never taught, was to actually talk about money or acknowledge that money like existed. By and large, all of the blood work that we do, even though it is much more comprehensive, we standardly look for Hashimoto's antibodies, for instance, and a number of other things. The majority of that's covered by insurance, so we do recommend people have health insurance. We're not a replacement for that. For the specialty testing, the average pricing is, so non-blood work testing, microbiome, genetics, usually about $100 to $200 per test. Those fees are to the lab, not to us. And we make an individual decision with every single member. Because our membership's annual, we don't have to do all testing day one. Some people come in and want every test I got because they sound like your friend Larry, and they'll pay anything for it. And some people, it's not in their budget. And then that's the nice thing about having an ongoing relationship with a team of doctors and coaches who know everything about you. There's a lot more to a person's health than numbers. And so we get as many as we can and make it an individual decision.
Next quick question. Yes.
Yes, absolutely. It happens all the time. I mean, I had a friend who came in because he was just feeling down and irritable. 78% of autoimmune diseases are in women, but he was a man, and we discovered he had Hashimoto's thyroiditis. All the psych drugs, all the therapy was a complete waste of time, and no doctor would have ever, other than us, would have ever even tested him or even looked at his thyroid. Oh, that's a woman's problem. So yeah, about 10% of our members, we call them members, not patients at Parsley, are what I would call the optimizer. They're people who are like, I'm pretty healthy, I'm just here because I'm into your testing and I want to improve, or maybe dad had heart disease. Most people come to us with a problem that they know that their conventional doctor can't solve, whether it's something as problematic but superficial. I've been through it myself, acne, to infertility, to Crohn's, colitis, and celiac disease. It really runs the gamut of severity, and they're looking for another way of solving it.
What about Andy or Nathan? Would you like that question?
Yeah, so we similarly probably go a little bit more extreme than you guys in terms of omic testing and so forth. So we might do on a patient that we see, depending on what the issues are, a focused panel of sort of non-CLIA approved tests, which are research tests in effect. And yeah, all the time you see things that point to areas in medicine where we wouldn't have looked otherwise clinically. And the best examples I can think of that right now are around metabolomics and around microbiomics. So, I've had patients come in and their clinical symptoms wouldn't have gotten you to suspect it, but if you look at the metabolomic portion of the test that deals with hormones, for example, you'll see all of the items redlined, right? They're not producing anything, so they have some adrenal issue that wasn't obvious from their testing, but might crop up that way. But yeah, so I think it speaks to an issue that in medicine we've really focused on point measurements, and that's what I was trained on when I was in medical school. But the technology's evolved so that it gets to be much cheaper to throw a broad net and then analyze that data. And I'm a computer scientist, and I have a PhD in computer science. But most of our colleagues in medicine don't have that, and they're not trained to look broadly at data. And I think that's actually something that needs to change in medicine. That soon it will be cheaper to do all of these tests. Right now, some of them are still pretty expensive, but within the next probably 5 to 10 years at the outside, most of these tests will be down to under the $100 price range, and it'll be cheaper to look at all this data at once. And then the question is, how do you correlate that back to a good outcome or a bad outcome? So I think all of us are chipping away at that picture in different ways, but that's a really important question.
More questions? Yes.
It's a really, really tough challenge, and it's something that when we first launched, we didn't know how to match up supply with demand. We just didn't know what demand was going to be like. But over the years, as we've gotten more experience, we now know what we can anticipate, both from consumers, and then when we onboard, say, a company like Walmart with 1.4 million members, how we need to make changes in our scheduling and our algorithms to make sure that it truly is on demand. And so the average wait time for a provider is about 3 minutes.
We do certainly for our participants. So the people that come through Aerovale, right, they're getting multiple blood measurements, and we also have all that Fitbit data and so forth. So some of the things, if they're doing, if they're taking actions, for example, to change their cholesterol levels or to, the whole slew of things, or they're trying to get leptin in control or something, basically we do have measurements for all those kind of things. If they're modifying their diet and they want to see if there's an effect on microbiome, that's another area that we can mine to look for patterns in that area. So we do have a very comprehensive analytic system that we've built out and are continuing to build out that looks at novel correlations amongst all this space. And one of the really interesting things that I didn't talk about is that you can actually use genetic risk itself as a phenotype. And what we've been able to do is to stratify really interesting differences in the chemistries of individuals as a function of their genetic risk for different diseases. And so there's a lot of ways that we're going in and mining this data, including for the wearables.
Questions?
We're not. We do take calls from folks outside of the U.S., and we are able, from a compliance standpoint, to receive those calls. We're just obviously not able to prescribe medication in other countries.
Yeah, so that'll definitely be like another phase of expansion. We're really focused on domestic for now. That said, we have members who are people around the world who've discovered us, who have seen us in person the first time or worked with us entirely remotely, and they are in other countries because they're looking for this kind of care. I already have physicians in the UK, Germany, and other countries, Australia, who want to anchor Parsley Health in those countries, and I'm frankly just not quite ready for that yet. But the operational challenges right now when we see people, even if they're in Canada, are simply that I can't order their testing in that country, and so they need to sort of collaborate with their local doctor. That said, the thinking and the expertise and the new view on their health that they receive through working with us is still immensely valuable. And at the annual price that we charge, it's something that a lot of people are excited and willing to pay for.
So we're going to end. Thanks for coming. And I want to thank each of these pioneers. These are amazing new companies using data and digital tools in new and different ways. And our hats off to them because each of them has taken big risk. And we want to see them all succeed. And of course, I want to see them all treat autoimmune patients. So thank you very much.